Hello everyone, let's talk about the natriuretic peptides. So natriuretic peptides are produced from the ventricle or atrium. So if it is produced from atrium, it is called as atrial natriuretic peptides. If it is produced from the ventricle, then it is called as beta natriuretic peptides. So in this video, we'll be mainly talking about beta natriuretic peptides. So beta natriuretic peptides, it is produced from what is called as pro-BNP. This is the first metal which is released due to the ventricular stress or stretch. The stretch of the ventricle, suppose this is the ventricle, left ventricle, stretch of the ventricle due to any reason will lead to release of pro-BNP. Pro-BNP gives what is called as BNP and N-terminal pro-BNP. So what is the difference between both of them is that BNP is the active metabolite, whereas NT-proBNP is just a protein and it is inactive. It doesn't have any actions as such. This beta natriuretic peptides, what does it function is that the name itself says that it has natriuretic effect. What do you mean by natriuretic is that Na stands for sodium. So it does natriuretic effect leads to increase in sodium and water excretion. Also, it causes vasodilation. So all these effects are useful in heart failure. So what will happen? So more sodium and water is excreted, so thus prevents the load on the heart. Also because of the vasodilation, there is decrease in preload as well as afterload on heart. Load on heart. So these two are beneficial effects of the beta natriuretic peptides. These effects are not there with NT-proBNP. Also, important thing, other difference between BNP and NT-proBNP is that BNP has a very short half-life, whereas this persists for a little more longer time. So also to remember now, what are the causes of BNP and NT-proBNP elevation? So it is not only elevated in the cardiac conditions, but also in the non-cardiac conditions as well. So first we will talk about the cardiac conditions which leads to BNP or NT-proBNP elevation and what is the mechanism of them. So most commonly, the BNP elevation is seen in heart failure. It can also be seen in myocardial infarction because of arrhythmias. Arrhythmias also leads to tachycardia and cause cardiomyopathy and may lead to stretch of the myocardium and can lead to release of BNP. Valvular heart disease, hypertension, cardiomyopathies, pericardial diseases, pulmonary embolism, and myocarditis. Coming to non-cardiac causes, the most common cause is the CKD. It can be also be seen in sepsis, COPD, pulmonary hypertension, anemia, stroke, and hyperthyroidism. So what are the factors which affects the BNP? So BNP is affected by age. So BNP level increases with age. It is more in females when compared to males. It is lower in obese patients. So in obese patients, there is increased clearance of BNP. So BNP levels are usually low due to increased clearance. Is that also renal function and medications. So we'll talk about RNAs and renal function here. First, talking about renal failure. So to remember that, we should know that BNP is cleared both by kidneys as well as by other enzymes in blood. Whereas NT-proBNP is cleared only by kidneys. And BNP is very sensitive to acute volume changes. So what does that means that suppose there is increase in the volume of blood in the heart or increase in the volume of water or fluids into the heart or in the body, it is very sensitive to that and BNP levels may rise because of volume changes. Whereas NT-proBNP is a more stable part and it is do not fluctuate much with volume changes. So volume status, it doesn't affect much. So important thing to know is that in CKD patients or in nephrology patients, there are frequent fluctuations in fluid status. Fluctuation in fluid status. So there will be more water retention because of decreased urine output, and also volume status keep changing there, and this also leads to change in the BNP levels. So BNP is not a very sensitive marker in CKD because it is quite unstable. It is very unstable here, and because of fluid changes, the BNP level keep fluctuating. So BNP should not be used as a marker in patients with CKD. However, NT-proBNP, limitation of NT-proBNP is that since NT-proBNP is basically eliminated by the kidneys, so in patients of CKD, these NT-proBNP levels will be definitely high. So when compared to BNP, these NT-proBNP levels will be high in CKD patients. So the margins of NT-proBNP has to be kept little higher. Like suppose if it is more than 400 is considered to be as raised BNP, in CKD patient usually it is considered to be as more than 1100 or more than 1500 and so. But only NT-proBNP is more sensitive in it, so only NT-proBNP should be used because it does not fluctuate much with the fluid status. So let's talking about ARNIs. ARNI is the medication that is called as angiotensin angiotensin receptor neprilysin inhibitor. So angiotensin receptor is nothing but it has an ARB, that is angiotensin receptor blocker, plus a neprilysin inhibitor. So this neprilysin, what does it do is that it has an action that, so there are natriuretic peptides. These natriuretic peptides are metabolized by neprilysin. So neprilysin, what does it do is all these natriuretic peptides like ANP, BNP, all these things are actually metabolized by the neprilysin. Now, what does RNA does is it inhibits the neprilysin. So this neprilysin is now inhibited, which leads to what is called as increase in natriuretic peptides, especially that is BNP. It does not have any role on NT-proBNP. Since patient on RNA, suppose a patient is on RNA, you cannot use BNP as a marker to monitor therapy because this BNP will be anyways raised in patients with who are on RNAs. So in patients with RNAs, you should definitely use NT-proBNP. So coming to BNP thresholds, less than 100 rules out heart failure. In NT-proBNP, less than 300 rules out heart failure. In acute settings, more than 400 is suggestive of acute heart failure and more than 900 of NT-proBNP. For chronic heart failure, suggestive of heart failure is more than 125 of BNP and more than 300 of NT-proBNP. So BNP versus NT-proBNP, as we've already discussed, it is all both are products of pro-BNP, and BNP has the physiological activities like natriuresis, diuresis, and vasodilation, whereas it is an inactive component, NT-proBNP, and there is no physiological actions. Its half-life is 20 minutes BNP, and it is 2 hours, 60 to 120 minutes. Clearance, BNP is cleared both by kidneys as well as by neprilysin and NPRC receptors. Whereas NT-proBNP is cleared only by kidneys. It is not cleared by neprilysin. Thus, it has no role on ARNIs. ARNIs has no role on NT-proBNP. Similarly, no effect on NT-proBNP levels, whereas ARNIs increases the BNP levels. Coming to diagnostic and clinical utility, diagnosis of heart failure, which we can use, it is BNP is useful, but it is influenced by the neprilysin inhibitors. That is, if patient is on ARNIs, you cannot use BNP as a marker. So especially in patient who is on ARNI, NT-proBNP is preferred. For monitoring therapy, NT-proBNP is preferred. Sensitive to acute changes. So as I've already discussed, BNP is more sensitive. It is very unstable and more sensitive to the acute fluid overload. Suppose patients of kidney disease have a slight change in volume overload and BNP fluctuates. There will be a lot of fluctuations of the BNP. So it better reflects the chronic heart failure status, which one NT-proBNP. So influence of renal function is that BNP is less sensitive to renal dysfunction. It is elevated in CKD. Also, obesity, BNP levels, because of there is faster clearance in obese patients, so there is BNP levels are usually low, whereas NT-proBNP is not affected by obesities. So this shows the diagnostic cutoff values. For acute heart failure, more than 100 of BNP, more than 300 of NT-proBNP, or the CKD, EGFR less than 30, you should not be used BNP, you should only use NT-proBNP, but higher baseline levels is kept. So let's coming to the advantages and disadvantages of each one. BNP has advantage that it reflects acute heart failure changes. Suppose patient was stable, suddenly develops heart failure immediately. Now for acute heart failure changes, BNP is very good. Suppose in ER emergency room, it is a very good marker for acute heart failure changes. And it is less influenced by the renal function. So it is not influenced by the renal functions as such. What are the disadvantages of BNP is that, as we have already discussed, it is affected by ARNIs. It has a very short half-life of 20 minutes. NT-proBNP is more stable due to longer half-life. It is preferred in ARNIs because ARNI doesn't have any role on NT-proBNP, and it is also better in obese patients. Important thing is remember that in CKD patient, NT-proBNP will be definitely elevated because it is removed mainly by the kidneys, and it is also the cost-wise it is higher cost in some settings. So impact of RNA therapies we have already discussed. BNP is increased. BNP levels will be increased on RNA therapy because it inhibits the neprilysin as well. So increased BNP levels due to reduced degradation. So in patient on RNA therapy, it is not recommended. It is unaffected by RNA therapy, that is NT-proBNP. So let's go to in any specific conditions, what are the preferred biomarker? General heart failure diagnosis, both can be used, both BNP and NT-proBNP can be used. Patients on RNA therapy, NT-proBNP, CKD, NT-proBNP, but the cutoff value has to be adjusted. Obesity, NT-proBNP, acute dyspnea, BNP for rapid changes. So for acute changes, always BNP is better. Stable chronic heart failure, NT-proBNP is preferred.